Hello, everyone. I'm going to get started while you filter into the room so that we can stay on time here. And I wanted to make some introductory remarks because there's a fair amount to share here about our speaker today. So Dr. Eve Kerr is internationally recognized for developing innovative, clinically meaningful methods to assess and improve the quality of care and decrease low-value care. She has dedicated her research career to understanding how to more effectively translate advancements from translational research to routine practice in order to improve patients' health and healthcare. I think this work is really relevant to the Regenstrief Institute's mission to recently drafted mission to develop, conduct, and disseminate impactful scientific research in health systems and across communities. In terms of leadership, Dr. Kerr serves as the Division Chief of General Medicine in the Department of Internal Medicine at the University of Michigan Medical School. She's a senior research scientist at the VA Ann Arbor Center for Clinical Management Research, where she previously served as director. And she's the founding director of the Michigan Program on Value Enhancement in the Institute for Healthcare Policy and Innovation. Dr. Kerr has been recognized for her scholarship, leadership, and mentorship, including of women, through elections to the National Academy of Medicine and American Society of Clinical Investigation. She's been the recipient of the highest career research awards from both the VA and SGIM, namely the VA Undersecretary for Health Award for Excellence in Health Services Research and the Society of General Internal Medicine John M. Eisenberg National Award for Career Achievement in Research. So those are both really big deals. And I could continue, but instead of doing that, it's my pleasure to welcome Dr. Kerr to Indiana for the Sam Regenstrief Distinguished Lecture Series.
Great. Well, thank you for that very kind introduction. And also thank you for the invitation to speak with you today. I wanted to say that I have no conflicts of interest and that you do get CME credit for this talk. So I'm really particularly honored to speak at the Sam Regenstrief Distinguished Lecture about measuring and improving value in healthcare. And just from the little bit that I read, I understand that that was a foundational reason that Sam Regenstrief founded this institute. So I'll be sharing some ways that I'm thinking about value in healthcare today. And I'll be really looking forward to your comments and ideas at the end of the talk, because some of this I'm just kind of developing. And so I, would really love to hear from a lot of smart people here about these ideas. So I'm going to start with some definitions of ways we can think about healthcare value. And I'm going to start with a case since I'm a general internist. I'm going to talk about Mr. H, who's a 77-year-old man with well-controlled diabetes and decreased vision from mild retinopathy and cataracts. He lives alone. He's on a fixed income. But he's really excited to be scheduled for cataract surgery because he otherwise feels, well, he wants to be more active. He thinks, he'll be able to walk more outside if he gets these cataracts done. So the surgery's scheduled in 2 weeks. The surgery team obtains pre-authorization from Mr. H's Medicare Advantage plan. And then where he's getting care, there's a required pre-op clearance checklist, and a chest x-ray and an EKG are ordered for Mr. H. And the EKG shows possible prior myocardial infarction. The doctor asked the patient about things like, no, I don't have any chest pain. Sometimes I get a little short of breath walking up a couple of flights of stairs, but that's been like that for years and years. But in any case, the PCP then orders a stress test, but the stress test can't be scheduled for 6 weeks because it's not an emergency. So his surgery is delayed. And while waiting, Mr. H falls and he breaks his right hip. So my question today, and a question that we'll explore a little bit through the course of this talk, is did Mr. H get high value clinical care? And a little bit of background, I know not everybody here are clinicians. So I want to talk a little bit about Mr. H's care and how it evolved. And this is a paper from one of our colleagues at Michigan, Dr. Leslie Dossett. And she highlighted through extensive literature review that routine preoperative tests, such as EKGs, before low-risk surgery, such as cataract surgery, do not prevent adverse events during or after surgery. And unnecessary testing is costly and can lead to other potentially unnecessary specialty consultations and invasive tests. And in Mr. H's case, an adverse outcome. And actually, this kind of adverse outcome is not that surprising. This is a paper from UCSF. They looked at 250,000 Medicare fee-for-service patients, not Medicare Advantage, with a biometry claim. And just to orient you briefly to the slide, the kind of light gray is low-value testing physicians, so low testing physicians of preoperative tests. And the darker gray is high testing physicians. And so the high testing physicians got preoperative tests more than 75% of the time. So as you can see here, the high testing physicians, the patients were more likely to fall, and they were at least slightly more likely to break their hip because those patients indeed waited longer for their surgery. So high levels of preoperative testing isn't limited to Medicare. This is a study by Dr. Nick Berlin, who was a surgery resident at the time with us. And he looked at preoperative testing in the Blue Cross Blue Shield of Michigan network for 3 very common low-risk surgeries: lumpectomy, cholecystectomy, and hernia. And the x-axis are hospitals. So you can see the hospitals across Michigan. And you can see really that there's huge variation from about 20%, 20-30% of hospitals getting routine preoperative tests to nearly 80%. Also variation across these procedures. So really, this is pretty common. And, when you order a low value test like that, obviously they're costly. But overall, that cost of the preoperative test was probably small. Was small in the big scheme of things for Mr. H. But still, getting those tests actually precipitated other downstream costs. So I want to talk a little bit about what else may have lowered the value of care. When we look at kind of inappropriate and unnecessary tests, that's kind of pretty obvious, but let's look at some other things. One of the under-recognized aspects of value in healthcare is clinician and patient time. So in this case, pre-authorization took time and approval was essentially guaranteed. In fact, I think now Medicare Advantage does not require pre-authorization, but that took clinician time away from other important tasks. The outdated pre-op clearance requirements in this health system meant the clinical teams spent time on ordering and following up low-value tests. The patient's time was spent on tests he didn't need, and it resulted in a poor outcome. And all of this increased cost of care. So waste like this is prominent in the U.S. healthcare system. This is a paper by Will Schrank and colleagues. And indeed, he found that overtreatment and low-value care is conservatively responsible for up to $100 billion annual expenditures, and administrative complexity like pre-authorization, fulfilling quality measures and things like that is responsible for $265 billion. And unfortunately, despite all these expenditures, we know that the U.S. Has higher healthcare spending as a percentage of GDP than any other industrialized country, and we also have worse outcomes. So, That's the very antithesis of high-value care. So I want to stop a little bit, and this is where I get to the part of the talk where I'm going to present some ideas that I'm going to want your feedback on at the end to think about what healthcare value really means and how we capture healthcare value. Now this, a lot of you are probably familiar with this equation. This is the classic model by Michael Porter that he forwarded in 2010. And he basically says that value in healthcare is, is equal to the outcomes achieved for patients relative to the cost of care to achieve those outcomes. So, as is obvious, you can improve healthcare value by improving patient outcomes, decreasing costs, or both. So another way healthcare value has been conceptualized is through the quintuple aim. Now, the quintuple aim incorporates the probably familiar to all of you triple aim from the Institute of Healthcare Improvement, which is improve quality, improve patient experience, and lower costs. So that was posited back in 2007. A few years later, they actually added clinician well-being, making the quadruple aim. And then back in 2022, Nundy, Cooper, and Mate wrote a paper adding equity to this conceptualization of value, noting that, of course, unless everyone has good access to high quality healthcare, we haven't really achieved value. So that's another way to conceptualize value. But when we measure value, we kind of put all those things in its own buckets. And I want to kind of think about how can we put all that together when we're thinking about value. And this is really an aspirational case about what we need to include in the numerator and denominator to really represent value in healthcare. And I'm going to not be able to cover all of this because we don't have that much time together, but I am going to focus some on quality and outcomes. So really kind of talking about some of these low value care issues that are typically not included. Clinician well-being, which is, despite being in the quintuple aim, isn't generally considered in value. And then I want to talk about overall clinical time and opportunity costs. So the cost of actually doing something that is unnecessary, whether it be administrative work like pre-authorization or tests, at a cost of not doing something that actually is necessary for patients. So when I think about healthcare value, within this context, I really do want to spend some time on measuring and improving low-value services because those definitely drive up costs, they potentially decrease quality, and they're often overlooked. So I want to think about, are patients getting all the care they need, but not care that they don't need or that may be harmful to them? And first, I want to take a look at whether patients are getting all the care they need. This is a paper we wrote back about 20 years ago now with Beth McGlynn, Steve Ash, and a RAND team to develop a comprehensive examination of quality of care. And in this study, we created 439 indicators of quality of care across 30 conditions and preventive care and applied them to over 7,000 patients living in 12 metropolitan areas in the US. And we found that any way you looked at it, the percentage of recommended care received was about 50%. And we suggested that strategies to reduce these deficits in care were warranted. So more than 10 years later, this was a study done out of Harvard where they looked, they used a completely different data set. They used the medical expenditure panel survey. They used a much smaller set of measures. I mean, so you can imagine the study that we did with so many indicators and so many patients, that was all medical record review. We were pretty confident of our results. This is from a survey, and they looked at trends since our study in quality of care. And the main thing I want to point out here is that the lines are pretty much flat. And so, regardless of the relative proportion, what they were pointing out is that quality of care is not really improving. They also looked at overuse of medical services during this time. And, especially notable, the blue and the is inappropriate cancer screening, and the kind of gray is inappropriate antibiotic prescribing. Those are really high levels of inappropriate care, as well as inappropriate, imaging and inappropriate cancer screening. So there's a lot of low value care that is going on here. So Aaron Schwartz, who was a MD PhD student at Harvard at the time, looked more broadly at medical services. He used Medicare administrative data. And he, so you can see all different kinds of data sources, but he measured 26 services that are considered unnecessary. And he found that overuse affected more than 25% of Medicare beneficiaries, which accounted for 2 billion to 9 billion Medicare expenditures in 1 year, depending on if he used the more specific or sensitive measures. And that's only for those 26 services that he measured. And the thing that's important here to think about is that while those were studies at the patient level, low value care, the root of it is often the system. And this is a paper by Dr. Ishani Ganguly and colleagues, and they used Medicare administrative data as well. They used measures from the Millman Health Waste Calculator. And you can see that the blue dots are places with lower levels of low value services, and those are all health systems. The dots are all health systems, and the red and orange dots are places with higher levels of low value services. So you can see, even though like maybe the red is clustered in the South and the blue in the North and the Midwest, but there's huge amount of variation, and this is at the system level. And variation isn't limited to Medicare either. This is a VA study done by my colleague, Dr. Samir Saini. And he examined variation at the facility level. So on the x-axis are the 120 or so VA facilities of overuse of screening colonoscopy. And again, found large variation from about 10% to almost 50%. So a five-fold difference of unnecessary colonoscopy screening across VA facilities, across 100 or so, 120 VA facilities. The other thing to note is that once we start a treatment, we very rarely stop it. And that is true even when that treatment could be potentially harmful. And so this is a study that we did in 2015 when we started to construct what we called de-intensification measures. So stopping or scaling back treatment or services that are not necessary or potentially harmful. In this case, Dr. Sussman looked at overtreatment of patients with diabetes by medications that could cause hypoglycemia, and found that even when patients had a very low A1C, less than 6%, very low, we very rarely stop medications. Here, 25% to 30% of the time, medications were stopped, even when the patient had a very low life expectancy. So the light bar is a life expectancy of less than 5. And that may be in part because we actually have many more guidelines and recommendations for intensification than for de-intensification. This is a study by Dr. Adam Markovitz, who was then a MD PhD student, will be joining our faculty in July. He did a review of diabetes and cardiovascular guidelines in 2016, and he found that of all the recommendations in those guidelines, 71% of them focus on intensification of treatment, and only 29% focus on de-intensification. So recognizing this gap, Tim Hofer and I, with a lot of help from our colleagues at our VA Center, developed a model for identifying, specifying, and validating de-intensification recommendations. We identified 178 unique opportunities to stop or scale back routine services across medication use, screening, and testing in adults. And then we put these recommendations through a pretty rigorous Delphi panel process to validate those recommendations. And we think that this study serves as a model for really identifying and validating measures of overuse for additional services. So I've showed you, I think up to now, that low value care is a problem. I've showed you that we can measure it, shown you that the system is important. What I haven't shown you is what do we know about reducing low value care? So let's talk about that a little bit. Dr. Johnny Anient and I wrote in the Harvard Business Review that there are kind of 2 to 3 root causes for overconsumption. There are the physician or system factors, so that's the supply side. And it's really hard to always know the right thing to do. For those of us who are clinicians, I think that resonates. And we often overvalue our own services. It's also hard to stop doing something once it's routine. It's hard to de-intensify. Incentives drive us to do more, we know that, and we are also worried about liability. Patient factors play a role, the demand side of the equation. And I think all of us feel that Americans think less care is rationing. That's a bad word. And that some beliefs about healthcare are hard to change, particularly when we don't have time for interactions and building that patient-physician relationship. Well, we wanted to understand some of this more from the physician perspective, and we surveyed primary care physicians, both in the US and in the VA. These are a random sample of primary care physicians about what a major barrier to reducing overuse was. And one of the things that was striking was the relative agreement between VA and US physicians, except for malpractice concerns. US physicians were more concerned about malpractice than VA physicians, and that was actually the main concern. But also patient requests for tests and treatments, the number of tests and treatments recommended by specialists, and lack of time for shared decision-making. These were kind of the top barriers identified. Interestingly, that study pointed out that physicians think patients want more medical care. So we asked patients. We did a nationally representative internet poll of 2,000 adults. These were adults 50 to 80. And we found that only about 14% of patients say more medical treatment is usually better. And about more than 50% said providers often recommend services patients do not need. So how do you cross this divide? That's what the Choosing Wisely campaign attempted to do. I don't know how many of you are familiar with it, but it was a campaign by the American Board of Internal Medicine Foundation. They partnered with a lot of specialty societies, I think over 80 at the end. Each society developed some recommendations, 5 things physicians and patients should question. And the goal was to help patients choose care that is supported by evidence, not duplicative, free from harm, and truly necessary. It became an international campaign, not just a national campaign. And so here you can see logos from Canada, Italy, Australia, the UK, Brazil. And I really feel that choosing wisely kind of changed the conversation about what we can do about low value care, but it didn't fix the problem. There's still a lot of low value care in the system. However, there have been a lot more studies, at least partly motivated by the Choosing Wisely campaign. I'm just going to mention a few studies that I think are informational. So this was a study that we did in both in the VA, the US, and in Ontario. This is a retrospective study looking at low value testing for vitamin D. And let me just orient you a little bit to the slide. Let's see if I can figure out the pointer thing here. So the blue line, that's the most striking line here. That's vitamin D testing in Canada. And you can see in 2011, that testing dropped nearly to zero. Well, what happened there? That was when Canada delisted routine vitamin D screening tests, which meant they basically stopped paying for them. And so you could see financial incentives work, right? I mean, vitamin D testing dropped to nearly zero. In 2013, that's when the Choosing Wisely US recommendation came out. And you can see that actually bent the curve here. The vitamin D testing in the VA, this was the expected rate, and it decreased, but didn't actually start to go down to still decreased from expected, but still was increasing. And in the US actually started to decrease. So the recommendations had some effect, but not nearly as much of an effect as a financial incentive. So this is, I think, a really elegant study examining gentle nudges instead of financial incentives. I'm gonna get rid of that pointer. So here, the authors use three different kinds of behavioral economics approaches: accountable justification, where people had to write in why they were ordering an antibiotic, comparing their ordering to peers, and suggested alternatives at the point of ordering. And what's interesting, I think, in this study is that you can see the control in the little circles. In the control, there was a trend for declining over time, but in the accountable justification and peer comparisons, that actually was worked significantly better, and you could tell that because the curves diverged. The suggested alternatives actually were ineffective, and if they hadn't had a control in this way, we wouldn't have ever known that, and we could have said, well, all three work pretty much the same. So again, really important to have robust methods. More recently, Dr. Kullgren in our group conducted a behavioral economics trial to reduce low value care among older adults. We did a step wedge cluster randomized clinical trial at 8 primary care clinics and 81 primary care clinicians. We wanted to avoid use in older patients of tight glycemic control, sedative hypnotic medications for insomnia and anxiety, and PSA tests for screening. And we had the clinicians commit. We had their photographs up on posters. They received weekly emails. Patients received some handouts before their visits. And we did find that across all three conditions, when we bundled them, which is what we were powered to do, we reduced use of low value care across those conditions. The intervention also increased de-intensification of hypoglycemic medications for diabetes, but not medications for insomnia or anxiety. But perhaps nothing has really shone the light on the need to improve value of healthcare as the pandemic. I think the pandemic really taught us that healthcare is a fixed and scarce resource. It's scarce in supplies, it's scarce in personnel, and that scarcity necessitated prioritization of vaccines, COVID treatments, non-COVID services. And actually that prioritization was made at national, state, and local levels, often based on benefit and appropriateness, and sometimes based on equity. And this is like my favorite depiction of encouraging people not to use inappropriate services, not to buy and take horse-sized doses of ivermectin. But that's kind of, was now in the public eye. So, okay, I've demonstrated that there's different ways to think about healthcare value. It's possible to measure inappropriate or low value services, and it's possible, but really hard, to decrease low value services. So now I want to move to talk a little bit about the under-recognized value of clinical work in the value equation. And I define clinical work as time spent doing clinical or administrative work required for patient care, regardless of whether it is billable or reimbursed. Okay. And that clinical work may be necessary, it may be wasteful, but it is still time that clinicians spend. So I think that this clinical work fits into this equation in two ways. First, it fits in the denominator as overall clinical time that sometimes isn't taken into account because it may be time spent, at home in the evenings and nobody knows that it's happening. And it also fits into opportunity costs because that time can't be spent then on something else. And it definitely influences clinician well-being. There have been multiple studies showing the correlation of administrative work with clinician well-being. So in 2019, again, before the pandemic, the National Academy of Medicine noted that over half of nurses, physicians, pharmacists, and medical students have symptoms of burnout. That clinician burnout is a workplace syndrome resulting from the imbalance between the demands of medical practice and the resources required to do the job well. And that addressing burnout requires improving the design and organization of the environments in which clinicians train and work. And this is really important because they shone the light on the system. Okay, it's not the clinician that needs fixing, it is the system. And this is another model by Schoenfeld and Noseworthy, looking at various drivers in the system that could lead either to burnout and engagement. At the very top is workload and job demands. And I put this up here because next time someone tells you that all you need is more resilience to address burnout, I want you to remember that it isn't about yoga, it is about the system. So I would say the pandemic has also accelerated the need to improve the value of clinical work. We know it's accelerated burnout among healthcare workers. Nurses and physicians are leaving healthcare in proportions we haven't seen before. And women and workers of color are disproportionately affected, and this has been demonstrated in multiple studies. The reasons are multifactorial, but a lot of it, especially for primary care physicians, has to do with the EHR, which again is kind of administrative work. The inbox, the other documentation requirements in the EHR has gone up 50% or more, depending on the system. So our Surgeon General, Dr. Vivek Murthy, said burnout manifests in individuals, but it's fundamentally rooted in systems. The causes include inadequate support, escalating workloads and administrative burdens, chronic underinvestment in public health infrastructure, and moral injury from being unable to provide the care patients need. So there's a moral imperative for addressing burnout, but there's also a business case. And this is something I always try to stress in our system. sometimes successfully, sometimes not, because it really does lower patient satisfaction. Burnout is associated with higher litigation rates and lower quality and safety scores. And there are higher costs associated with lower productivity and turnover and effort reduction. For clinicians, there's a disproportional effect on women, so there's an equity issue, higher incidence of depression, and many other factors associated with that, and lower achievement of professional satisfaction. So there's some real costs to burnout. And in this study, this is now using $2015. The authors pointed out that there's $4.6 billion a year related to physician turnover and reduced productivity is attributable to physician burnout. So these are real costs for the healthcare system in general. So in a follow-up to their 2019 report, in 2022, a National Academy of Medicine created priority areas for addressing clinician burnout. And these are all important. I'm going to focus today on these issues of clinical work, which I think hit the priority areas of creating and sustaining positive work and learning environments, addressing compliance, regulatory and policy barriers, and engaging effective technology tools. And this is a viewpoint that we wrote a year and a half ago about enhancing the value of clinical work. And we actually borrowed from the Choosing Wisely framework, and we called it Choosing Wisely to Preserve the Clinician Workforce, where we said the decade-long quest to improve the value of healthcare delivery has collided with a demoralized healthcare workforce, creating a unique opportunity to improve healthcare work environments by applying a Choosing Wisely mindset to clinical management practices. So in this study, we said that we titled problematic management practices are ones that create unnecessary burdens to the clinician workforce, do not have sufficient evidence base, do not address outcomes patients care about, and are duplicative or waste time. We really felt that the prioritization should come not just from the top down, but from the bottom up, where clinicians are engaged and involved in saying what we should stop. We recognize we need to coordinate regulatory efforts because we can't stop things that are required by the Joint Commission or CMS unless the Joint Commission and CMS changes their rules. And that we need to support research using a de-implementation framework that was often developed in conjunction with the Choosing Wisely campaign. So we actually, for the past year, have been doing this at the University of Michigan. We formed a task force on choosing wisely to preserve the clinician workforce. We engaged hundreds of clinicians for feedback and a working group with multiple stakeholders. And on the left, these are all the prioritization areas that through this process we determined and disseminated. And on the left are areas that we're going to be actively working in order to try to reduce administrative burden at the University of Michigan. So I haven't spent my career measuring costs. I spent my career measuring quality, but I recognize that costs are critical to the value equation. We really have to, kind of think about the way we measure costs. Most health systems take shortcuts. When they think about costs, they think about looking at charges or claims or reimbursement and saying, okay, that's the cost. But back in 2011, the same Michael Porter from the Porter model and Robert Kaplan actually said, that's not right. They said we need to abandon the idea that charges billed or reimbursements paid in any way reflect cost. That cost depends on how much of a resource's available capacity or time is used in the care for a particular patient, not whether the charge or reimbursement for that service, not on the charge or whether it's reimbursed at all. And as a primary care doctor, we don't get really high reimbursements. So this rings really true to me, but also as a primary care doctor, our doctors spend so much time at night, on the weekends, in between patient visits. All those things are not documented. And to the system, it's like they don't exist because they don't pay for it. It's not reimbursed, but it is real time. So again, when we talk about measuring and promoting comprehensive value, how can we make an equation like this work? How can we capture some of these nuances in the, well, maybe not nuances, factors in the numerator and the denominator, so that we're not just talking about patient outcomes over the direct cost of services, but we're really looking in totality at healthcare value. And, I know that this is aspirational. I haven't worked this out yet either. So this is an area where I would love your feedback, because I think this is actually an important role for academic medicine, is to be thinking about how we do this better. And I think in academic medicine and in all the research that you all do here, we can do a lot to improve the value of clinical care and clinical work. We can prioritize, implement, and teach about high-value care and high-value work. We can start choosing wisely, both by stopping wasteful clinical and management practices. We can collaborate internally and externally to drive change. Importantly, I think we need to develop new ways to measure all aspects of healthcare value. And for academics in particular, accelerate innovations and research to improve the value of both clinical care and clinical work. So 10 years ago, the National Academy of Medicine said, a health system grappling with increasing pressures to improve quality while reducing cost depends on the tools of innovation and workforce effectiveness and efficiency to achieve the triple aim, because it was still the triple aim then, to better care, lower costs, and improve health outcomes. Stewarding these capacities is critical to the future of American health, and that function depends on the success and adaptability of academic health systems. In 2022, the National Academy of Medicine said the national plan's vision is that patients are cared for by a healthcare workforce that is thriving in an environment that fosters their well-being as they improve population health, enhance the care experience, reduce costs, and advance health equity, therefore achieving now the quintuple aim. And in 2022, Vivek Murthy said the time for incremental change has passed. We need bold, fundamental change that gets at the roots of the burnout crisis. We need to take care of our health workers and the rising generation of trainees. So I will posit that the who is us, and we must act because our health system depends on us, because our patients depend on us, and because our colleagues depend on us. The time is now for academic health systems to promote transformational change that drives comprehensive health system value. Thank you, and go Blue. I'm actually supposed to put up the slide, but.
If anyone has any questions, we have 2 microphones set up. Please remember to turn them on before you start speaking. And if anyone online would like to post a question or ask it directly, just type in a message and we'll make sure that you're heard. Thanks.
I can't help myself.
Please.
Early in 2023, I had 3 surgeries done in the same hospitals within 6 months. And they want to do pre-admission testing for all 3 of them. They were connected to a system where all my primary care data were available. They didn't do anything in that pre-admission testing that hadn't been done in a recent primary care visit, except for the unnecessary EKG. Mm-hmm. And yet they did it because they said, well, Siri's not going to operate if we don't do it. Right. So I talked him out of the last 2 because I said, I just had one, I'm not going to do it again. Yeah. But an approach for this, you said it's up to us to do it, but why do the insurance companies pay for it? if they know that pre-admission testing is not worthwhile, just say, do all the pre-admission testing you want. We're not going to pay for it.
Yeah.
So if they know what low value care is, then they shouldn't be paying for it. That's the first thing. The second thing is when physicians are working and non-physician, the other clinicians are working out of hours, pajama time, they're not seeing patients. They're documenting or they're going through their inbox.
Mhm.
The reason why documentation is a problem is that E&M approach to billing happened 15, 20 years ago, and they based on the clinician note how much you get paid. So the more crap you put in the note, the more you get paid. Stop it.
Mhm.
And why the physicians continue to do that, they say, no, I'm going to write what I need to put in my note to take care of my patient. Somebody else can document for billing. That's not my job. And we don't do that. They just do pajama time and take family time or sleep time away. I don't understand that. I don't understand why, especially when you've got a discipline, primary care, that is in great undersupply right now. Just say, we're not going to put up with it anymore. We're mad as hell. We're not going to put up anymore. I've actually got a picture. So I have a slide with that on it, but I don't know why they're putting up with it. Just say, no, we're not going to do that. We're going to practice medicine the way it ought to be practiced. If you don't like it, then hire somebody else.
So I'm glad to hear you're as frustrated as I am. Maybe not so glad. I guess that means it happens here as much as it happens at Michigan and other places. I completely agree. Your first point about the preoperative testing and not paying for it. That one of the things we need to demonstrate is that we can actually measure that accurately. We can measure that it's unnecessary. And that's, among the things that we're trying to do. I mentioned Dr. Dasa, the surgeon who did some of that work. She has a ARC-funded intervention now, actually like across Michigan State to lower the use of unnecessary preoperative tests. I think like Blue Cross Blue Shield in Michigan would love not to pay for it. Sometimes those tests are necessary, right? There are times when it's appropriate, but especially for low risk surgeries, I really do think we can eliminate most of them. So I agree. I think that we need specific ways to measure it, and we need to do. I showed you the vitamin D study. You're not gonna, if you don't pay for it, you're gonna stop doing those things. The other point about how primary care is paid, I also agree. The fee for service approach, obviously just doesn't work for primary care. And, for a health system, our system knows that pajama time is a huge source of dissatisfaction for our physicians, and the in-basket is a huge source of dissatisfaction, but they're not paying for it. They're paying the doctor's salary the same, right? Whether they do 20 extra hours or no extra hours. I think we need both to pay for care differently. And we need to think about what care means differently, right? Because that time in the in-basket is real patient care. Right? We think about that as some extra thing, but we're often responding to questions that patients really need the answers to. Renewing medications that patients really need. Some of that could be done by other clinicians, right? It doesn't all have to be done by physicians. And so that is, I think, one particular solution. And then we need to start thinking about that comprehensively, because if patients want to get their care that way, if patients want to get their care asynchronously, and if that's safe, then we should incorporate that into medical practice and create time for doing that. We're trying to do some of that at the University of Michigan. We've given everybody 20 minutes for 4 hours of practice. We call it a portal practice slot, to answer urgent messages and, do other things. That was hugely controversial in our system. And I can't even tell you how many meetings I went to try to get that approved. And you'd think 20 minutes doesn't make a difference, but actually our physicians say it makes a huge difference to them, partly because it gives them some autonomy back, and partly because it gives them some time to get to urgent things during the day. And so they're not so worried about like what's going to happen at the end of the day if I didn't see that message.
Thank you so much for a great talk. So maybe a comment and then a question. The comment about the workforce burnout and it's not more yoga really resonated with me. And it kind of draws parallels, I think, to a lot of the conversations we're having just more broadly about thinking more of our conceptual framework being multi-level, and that if we want to have the biggest impact, we need to go up a level. And so thinking about the same parallels with, it's not just about if we want to fix patient outcomes, we don't just have patient level interventions like it's more education. We have to think about what are the system level effects. So it really draws some parallels with some of what you were talking about and not more yoga. But that made me think about, so if you go up multiple levels, you think about the health systems wanting to, address workforce burnout. And I know we have our local health systems care about that topic a lot, but there's also the incentives for them to do so may not always be aligned.
Yep.
So I wonder if you could speak a little bit about, what is some paradigm shifting strategies or something above the level of the health system, or policies, maybe a good example where you could have a really big change. One that might come to mind is, think about, it could be more local level, but residents unionizing and thinking about work hours. Are there other things, at the policy level, that you think will make a difference that may be more aligned or create that alignment with the health systems making the decision to promote that workforce and reduce burnout?
Yeah. Thank you for that question. I'll say a few things. The first is money, right? I mean, that our health system keeps on saying, well, we can't afford this and we can't afford that, and our margin's too small. And I get that, right? It's, the reimbursement over prices have gone up, salaries have gone up, cost of everything has gone up, our reimbursements haven't gone up, right? And so the first is money. I mean, I think we have to really kind of think about what are we paying for, and maybe definitely have different models of payment, which likely, at least for primary care, includes capitation much more robustly than what's happening now. And it's a little ironic because I started my career back in California, actually writing about capitation, some of the problems with capitation. So that's not like a perfect system. I think, we have to really get that right. The second is accreditation standards. And so, you see the system jump through whatever hoops are required when the Joint Commission says they have to. NCQA has the patient-centered medical home accreditation standards. I'm actually taking a sabbatical in a few months, and one of my goals is to work with NCQA to think about updating PCMH accreditation standards, and ideally linking that with, payments. So that is, I think, another way that we could kind of start thinking about more broadly. I think fundamentally what Bill said was like, we're not going to be able to sustain primary care in the way we're doing it now. And I'm talking about primary care, but this can generalize to other clinical disciplines. We're not going to have enough doctors. I mean, there's no way. It's impossible, not with our current pipeline. So we do need a paradigm shift about how we're going to take care of all these patients. I think we're going to have to realize that not everyone's going to have a physician taking care of them, and we have to have some different models for, both synchronous, asynchronous care, use of team-based care with ancillary support, mid-level providers, physicians, in very different ways than we're doing it now. And it's probably all three that has to.
Thank you.
We have a comment online. This is from Greg Sachs. Great talk and an impressive body of work, Dr. Kerr. My elephant in the room question, can you comment on the extent to which the profit motive drives so much of these problems? U.S. has an amazing array of insurers, health systems, middlemen, and clinicians who want to extract money for themselves. Clearly, a major difference between our country and others that do better.
Yeah, thanks so much. Yeah. I don't know what else to say to that, except that it's a huge problem. I'll say that it's a very confusing system because we have private payers and we have state and federal payers. But it's not perfect anywhere, right? Like I've done a lot of my work in the VA, and it's not perfect in the VA. We have burnout problems in the VA. We have overuse in the VA. I've shown you some of that. And we've essentially cut out a lot of the middleman, right? And so no question that the profit and the margins and the lack of payment drives some of this. I personally think the VA system is better, but I've been a VA clinician for many, many years, and I've done a lot of stuff. I didn't show you comparisons of VA and the US healthcare system, so I have some evidence to say it's better, but it's not perfect. It is definitely, we need reform in that area, but that's not the only thing we need to reform.
Another comment. Do you think a well-trained LLM with extensive knowledge of health data standards, billing codes, et cetera, might help fill the gap for these administrative tasks, manage inboxes, assist with documentation, and give back some time and cuts costs, excuse me, especially for private practice and rural hospitals? It seems physicians moving into private practice and cash pay models is more attractive if sustainable.
So an LLM? Oh, okay. Thank you. See, this is not my language. So I am not the expert in AI. You all can answer those questions, much better than I can. I could shift that to you, perhaps. I think we need need help wherever we can find it. I think some of that can be helpful. I mean, certainly technology can be helpful. In the end, medicine is based on relationships, and this is particularly true for more complex problems. And so for healthy young people, there's probably a lot you can do, both with self-management, access to technology, and a lighter touch with clinicians. But I think ultimately, ChatGPT isn't going to replace doctors. I'm not sure that was a question, but if someone else wants to answer it, I'm happy to let them. Last one, good.
Fantastic presentation. I'm really excited. So one of the things, and I obviously, I mentioned that I do burnout research, and documentation is huge in that. And I wonder if you've ever thought about high value and low value documentation, and whether or not that has an impact. And it certainly has an impact on burnout.
Yeah.
Whether it's the VA, the burden is one way, and outside the VA, it might be payer driven. Thanks.
So, yeah, thanks, Angela. Absolutely. I think Bill talked about this too. Like, why do we put all these things in? And I actually think the E&M move to time versus, kind of documentation of the elements of the visit has been helpful. Although it's kind of hard to break that habit of, documenting, X number of points in the review system. So yes, and this may be a place where AI could be really helpful. Like, we have, like for Zoom, we have I guess, some kind of AI transcriber, right? Like someone listens and transcribes. Like, then you just have to fix your notes. So that's already being used. I know that, but for what we should go back to thinking that documentation is for communication and not for billing, right? And if we did that, I think the documentation burdens would be much